too much light, probably because you want to see the image. We know we want this kind of light for us. It's better for radiologists. We are like home. Okay, well, I hope you like my presentation. That's what I'm talking about. This is where I come from, the very south of Spain. I'm from Cádiz, which is a marvelous city with all these views and beaches and sun. This is from my mobile phone last week. And this is where I live in Jerez, nice city as well, with wine. So I invite you to come whenever you want. Well, this is my current situation. Well, this is where my hospital situation. We are 10 population of around 500,000 people. The area is very wide. From one place in here, let me show you. From this city to this town in here, we have, can you see it? No. Okay. Laser pointer, okay. From here to here, you have more than 2 hours by car. So we are a spread area with a lot of small cities with few people, and then in the center we have Jerez, which is a medium-sized town with 250 people, more or less, 1,000 people, more or less. We are almost 4,000 professionals. In my department, there are 18 radiologists, so you can see we are very few. And we had to externalize a lot of exams, most of them MRIs and some CTs. And we do a lot of X-ray, but we are not able to inform all of them. I'm sure you have the same problem in your hospitals. That's what I'm going to talk about. I have already talked about the current situation. I'm going to tell you our experience with volume RAD. Afterwards, the advantage and consideration of using this technique. Afterward, we will talk about the uses of digital tomosynthesis in emergency trauma pathology, some little clinical cases. What we do with follow-up exam, but I won't be very long talking about that because Elisa will talk about that better than me. She has more experience. I have just 1 year of experience. And then like a summary of everything, okay? Well, our first equipment, we got it in the COVID area, in the COVID third or fourth wave. We get the equipment without asking for it, and I decided to set it next to the COVID patients. We had 2 hospitals connected, but they are quite far away from each other, so I decided to put it next to the COVID patient area. But after some changes in the hospital organizations, the COVID patients moved to the other part of the hospital. So it was a pity because I couldn't do the exams in the COVID patient as I wanted, as I could see with Dr. Juana Plasencia, who is here. She works in Murcia and in Morales Messenger Hospital, and they were doing such a great job, and they were very helpful for us. So I wanted to do that, and when I realized I couldn't do that, I went like, okay, I forget about tomosynthesis. After the COVID area, I had some happy event. One of the GE professional who helped us to implement this technique, he came to my room and he asked me, well, I had a car accident, not very important one. And he told me, I have a anterior left rib cage pain, and I can't see anything in my X-ray. So here we are. This is his X-ray. Nothing very important in it. I look at the additional projections for the rib cage. I couldn't see anything, but he wanted to do another technique. So I tell him, okay, we can do an ultrasound to see if you have any rib fracture. And he told me, no, we are going to do a tomosynthesis. Okay, let's do it. If you want to do it, let's do it. And I was very accepted about that. But that's what convinced me about the technique. This is, as Nerea has told us, the plans, all the images, slices from anterior to posterior. We are focusing in the anterior structures and then going to the posterior one. Here we can see the corner rib and sternal joint. And as we go posterior to posterior slices, then we can see some of the ribs, okay? So after looking for them, I don't know if you can see it, we found the fracture. It's very clear. You can see also the cortical damage. So we found the fracture. I was like very happy, and then I started to think that it could be a good thing to do to keep on studying this kind of lesions. So after, with this technique, we also can check the rest of the chest, the lungs, the mediastinum, the ileums. Elisa will tell us about all this chest X-ray, but it's amazing, the quality of the image, and you get very happy and very, yes, you are happy to see there's nothing else, and that's true. You can see the ribs on the posterior slices, and so it was perfectly normal except for the rib fracture. So I decided that I need another equipment for my emergency area, and this year we got it. We've been working with it since April, middle of April. I think that there are so many advantages, and Nerea has told us some. I'm sure it has a better diagnostic capacity than usual digital X-ray, that's no doubt. It allows us to save projection and adjust the radiation dose. We can improve also workflow. We'll see later on how can we do it, avoiding extra exams, so like more projection or CT scans. It will be used to discharge this CT scan in the emergency area, and this diminish its use in some pathologies. We will see later. But we have also taken into account some consideration. It's true that the exposition time is not very big, but when you have some elderly people and you need them to do an apnea, sometimes it's not possible to get an apnea of 11 seconds in an old man, 89 or something, that have a thoracic trauma. So if you can try it, but if it doesn't work because it breath, you have to do the common X-ray projections. It also requires a proper positioning and to do a correct choice of the plane, if it is axial or coronal or sagittal, depending on the joint or the pathology you are suspecting. Well, we have a problem. I don't know if you have it, but in Spain we cannot. We don't have a proper exam request in our RISC program. So we just order an X-ray, ask for an X-ray, and if we want to have if the emergency doctor or the trauma or the orthopedic doctor want to have a tomosynthesis, they have to put it by hand. I mean, I want to have a tomosynthesis. We cannot order it. I don't know if you have the same problem in your countries. And I'm trying to make a change in it, but it's quite difficult. And also, you cannot perform tomosynthesis in the patient's bed. It's also for wall bookie and table, but it's okay. I mean, you have these limitations, but I'm happy with that anyhow. Well, in the emergency trauma pathology, I think digital tomosynthesis can help us to locate the bone fractures, also assess of the displacement of the fragment. It's very, very, very good at finding hidden fractures, also checking joint involvements in these fractures. And it also helps in evaluating the immediately orthopedic or surgery treatment. Some of the reason Nerea told us already, because we don't have the artifact of metal of the prosthesis, so that's very, very good. And it's also a good technique in assessment in fractures consolidation, because we can see the new bone earlier. So I was determined to implement this technique in my department. So I thought I should start it by us. I planned a training in our department. First of all, we do the trainer in radiographers. They were very, very happy with the technique because it's very easy to use. You just have to choose the protocol, and that's it. Afterwards, I tried to convince my colleagues. It was a little bit harder. A few of them were like, this is not with me. But after I showed them some cases, they thought, okay, maybe in our 24-hour shifts, maybe when we are on call, it can help to diminish the CT scans we do. Okay, and now they are performing very little, but little by little, we are getting used to this technique. Second thing to do was to tell the emergency department we had this technique in the hospital. I went to a morning meeting with them, and I explained them the technique and what they can do with it. They were very enthusiastic, very, very happy with that. We decided what we were going to do. We just choose 3 protocols, coccyx, also rib cage. And when they have doubts with chest, they perform tomosynthesis before any other exam, or like CT. And in the initial follow-up, we had some troubles with visualizations of images in their computers, but we saved them, and now they can see them very well. Our current workflow is nice. Some of them want to open and do more tomosynthesis in other joints. When they asked us, we allow them to do them because it's a tool, a very useful tool for them. Well, I want to point out that we had to train these people to see the images, because they watch it in their every patient they see, almost every patient they see, they have a X-ray exam. So if they ask for a tomosynthesis, they need to know how to read it. So it's easy to tell them, but it's a need we have, because we cannot read all the tomosynthesis we do in the hospital. Well, third point was training the orthopedic surgery department. and I went to a morning meeting, but it wasn't as easy as with the emergency doctors. They were focused somewhere else, I don't know. They are surgeons. So I tried, but they were asking some weird questions not related to tomosynthesis. So I have a lot of current work with them. What I try to do is when I'm in a 24-hour shift or on call, and they ask me, can you see this X-ray? And we have doubts. I say, okay, before the CT, we can do the tomosynthesis. But it depends on the radiologist who is in there. They do it or not. But we are trying to do some work with them. I will show you now some cases. Well, the first one, Antonio's one, is fantastic. But this is a friend of mine. This is before we had the second equipment. My friend fell on the street, fell on the street and had a thoracic trauma. She didn't tell me anything. She went home after going to the emergency area. And after 2 days, she phoned me, Maria, I have a very big pain and I can't breathe properly. Can you please see the X-ray they made us? They made me. Yes, I look at it, and this is the X-ray. I don't know if you noticed something. Yes. Nobody saw it in the emergency area. Well, they have a lot of patients. It could happen. This is the exposition for the rib cage, and you can see it better in here. She had a wide pneumothorax in here. That's why she couldn't breathe properly. So I tell her very calm, I tell her, well, I think you should come again. You come and visit me and then we'll see what we do. So she came to the hospital and she had to stay with a thorax tube to remove this air from the pneumothorax. When she was recovering, she was asking me, why has happened this to me? And I said, I'm sure you have a rib fracture, but I can't see it. So she told me, how come you cannot see it? Because I had so many X-ray projections. I said, okay, don't worry, we will find it. I will do a tomosynthesis, and that's what we do. Before they put out the tube, we do the tomosynthesis. We were looking for it until we found it. So that's very nice image as well. And she was happy because she had already know what happened to her, and now she's well. Second case, it was on with the new equipment now in the emergency area. I was on my 24-hour shift, and a doctor came with some doubts. This 28-year-old female complained without any trauma because she had pain in her chest bone. She had a previous history of cesarea 3 weeks ago with no complications. So they told me, okay, we see this area here, and the girl has this chest bone pain. We want a CT scan. And I say, okay, she's 28. Please let me try something else. The chest bone is missing. We cannot see it in here. It's impossible. So I decided to do the tomosynthesis, and that's what we find while we are going from anterior to posterior slices. We can see the sternum, the chest bone, sorry. We can see it's fine. Nothing happened with it in it. And then we study the chest, and we see this pneumonia in there. We can see it very clearly, how it involves the fissura in here and the extension. So she went home with antibiotic and something for her pain, and she didn't undergo any CT scan, so that's nice as well. Well, this is also from one of my shifts in emergency. This 53-year-old man with left knee trauma and pain. The orthopedic surgeons had some diagnosis doubts because they thought the patient has something in here, and I said, I think this is like cyst, and this is not a fracture. But we really cannot see anything in here. I don't know if you do, but I don't really see anything. So, and they asked for a CT exam, of course. And I said, okay, let's do the CT, but I'm going to do the tomosynthesis before. And that's what they do. This is from anterior to posterior. We have the rotula here, and we have the knee. Each protocol, you can, as Nerea has told us, you can change the number of slices, the thickness of these slices, without any radiation dose changes. So I haven't put all the images in the cases. I just choose the ones I want, because there are like 40 something for each case. So, and we see here the cyst very nicely. When we went from anterior to posterior, we can find this one. And I said, okay, here you are. You have your fracture here. You don't need the CT, but they wanted a CT. So we form it. So, and that's it. We see the cyst in here. We can see the fracture in here. But the nice things about this case, I think, is this correlation of images between tomo and CT. That I think that's marvelous, and with this reduction of those, it's amazing. I mean, if they believe in that, it will be fantastic for the patients. Also the cyst, I mean, no doubt anymore. My fourth case is a nurse who works in my department, 62-year-old woman with right knee pain after falling down at home. Well, sorry, we cannot see anything here, but as she had remaining pain, she asked for an MRI, and as she was working in the radiology department, everyone said, okay, let's do the MRI. And in the MRI, we can see some fracture line here and something fracture in here as well. We have the two T2 images, and this is all the edema here and in here. So, as we didn't see anything before the follow-up exams, I decided to do it with tomosynthesis, and that's what we do. And in the tomosynthesis, we can do the fracture here. Not the one in here, but in here, okay? But this is very clear. The nice things, again, is this image in here and in here, this correlation with tomo and MRI. So, it's not normal, it's not a common way to do an MRI exam with a not very problematic knee pain, but you can avoid doing it by doing tomosynthesis first. Well, any other area of interest, I just put these 4 images of coccyx. Who among you have ever seen an X-ray exam of coccyx with the hope of watching any fracture? Please raise your hand. Because every time you see a coccyx X-ray, you say, I won't see anything. If you have pain, you sit in a cushion, but that's it. But now we can see it. We can see there's no fracture in this coccyx. So we decided to perform in every coccyx trauma. It's a lateral projection, and the protocol is very simple. You can see the coccyx, you can see the rectum as well, as you see. Well, I'm not going to talk a lot about that because Elisa will tell us everything about the chest, but we are trying to do some follow-up in thoracic pathology. We interact with the infection disease department in tuberculosis and HIV. In tuberculosis, as you know, many department, gastro department, the rheumatology, a lot of medical doctor goes for biological treatment lines, but they had to do a screening of tuberculosis before. And the infectious disease department was like overcome with all this, and they asked us for help. So we are evaluating all the digital X-ray they are doing, and if we have any doubts, instead of making a CT, we are upgrading the digital X-ray with the tomosynthesis. So that's why that's what we are doing now, and we have to evaluate the work. But I think it's very nice. And the other part is with HIV patients. They have high risk of lung cancer, so we are preparing a study with comparing digital tomosynthesis, replace digital X-ray, and compare it with a low-dose CT scan, and we will see what happens. But I have a lot of hope that it will be very, very nice. So that's what we do. And as a summary, I will tell you what I think about the technique. I think it's very important to establish a specific indication to perform the digital tomosynthesis and adapt the protocols to them, the plane, the slide thickness, the number of images. It is very important to provide the necessary training to the departments involved, so that they can see the images and they don't have to ask us everything. But we have to lead this training. I think we need to lead this. It is important that when we perform these protocols, we make change in our workflow so that we can improve patient's experience and save time and radiation, decreasing additional exposure and reducing CT scans. That's our goal. I hope next time I can tell you we got it. Also, digital tomosynthesis is a powerful tool to detect hidden bone fracture, as we saw before. In these cases of pain persistence with normal X-ray exams. And it may precede CT scan whenever it is possible due to its low dose. Also, it may be considered as the first technique to perform in cases of rib cage fracture. I have no doubt. It dramatically increased the diagnostic precision and reduced X-ray projection and global radiation dose if we sum all these radiation dose from all these projections. And what should be coming? Well, we need to improve these patient pathways and operational efficiency in the emergency areas. That will help all of us, the patient, but also our work in this area. We have to try if it has clinical value maybe for this bone tumor with low risk of being malignant. I'm sure we can decrease the number of CT scans we do by doing a tomosynthesis, because it clears up everything, and if it is a low risk bone lesion, we can stop with that. And I'm sure someone is going to study that, probably. If I don't, we need some AI tools to develop, like Mammo-like, So that's what we need from you, because it has a lot of images and we don't have time in the emergency area. I don't know if you have any questions, so I hope you like my position, and that's it.